Good afternoon. Could you please take your seats? We can start the session on time in order to respect the timelines. My name is Ursula Kirchmeier. I'm a pharmacoepidemiologist in the Department of Epidemiology in Rome, Italy, and I'm happy to co-chair this session on drug utilization in pregnancy together with my colleague.
Hi, I'm Cécile Droz-Perotto. I am the director of the team of Bordeaux Pharmacoepi platform based in Bordeaux in France. And I am very happy to be here today with you in this session. Just some words for the organization. We have 10 minutes and be sure to respect the time to present. And after that, we have 5 minutes for questions. If you have questions, please raise your hand and you have a microphone to ask questions, state your name and your affiliation. And after that, enjoy the session.
So our first speaker is Albert Prats-Uribe, who comes from the University of Oxford, and he will present results from the Darwin study on the use of valproate in 5 European countries. Please.
It should be here.
It's one of the, yeah.
There we go. Hi, thank you. My name is Albert, and I'm going to present one of the first studies that we did as part of the Darwin EU initiative, where we looked at the use of valproate in women of childbearing age. So disclosure, this is first, it's our views, not the views of the European Medicines Agency. And I don't have any conflict of interest regarding this. Here you have 2 big QR codes. These are not part of the scavenger hunt. These are just a Shiny app and the report of the study, where we have a lot of information extra to what I'm going to present. So a little bit of background. Valproic acid or valproate, it's a medicine that is used basically for epilepsy mostly as a main indication, but then is also used as a second-line treatment for bipolar disorder and migraine. But we know that it's teratogen and thus could provoke congenital malformations if taken by women, pregnant women. So the EMA asked us to look at different countries in Europe, the use of this medicine over the years. And also we know that the EMA has issued risk minimization measures in 2014 and 2018, limiting the use of this medicine in women of childbearing age. But here we're just going to describe the trends. So the objective of the study were basically this incidence and prevalence of use of valproate in women 12 to 55, that is how we define women of childbearing age. And in the Shiny app, in the report, I'll put the QR codes at the end if you want to take a look. We also look at all the alternative drugs for the indications I just explained. And we also looked at how these women look in terms of comorbidities, other drugs they're taking, and so on. So these are data partners of the first year of Darwin, but here we used 6 of these data partners, UK, Belgium, Spain, Finland, Netherlands, and Germany. And basically our variables are relatively simple. Valproate was our main drug of interest, and we did 5-year age bands, and we looked at all comorbidities and communications, and I'll show you some of them. This is part of the rapid analytics we're doing in Darwin. We have a catalog of rapid analytics, and I think you'll learn more about this later in my colleague's Danica presentation and on Sunday on the Darwin on the Darwin session. So what did we find? Basically, what we kind of were expecting, that it's that the incidence and prevalence went down during 2010 to 2021, and that this was more like there was more diminishment of the incidence and prevalence in the younger age groups, so reassuring results. Here I show the incident use, so the incidence of valproate. Let me get here. So here we have incident use of valproate per 100,000 person years in women of childbearing age, and the year. And as we see, some databases had a high incidence at start, but they all go down over this 12-year period. This is prevalence, so we see still many databases that go down during this 10-year period, but the prevalences were also relatively low already for some of the countries. And I like this graph that it's the same prevalence of use of valproate in women 12 to 55, but it's stratified by age group. So in the bottom, we see that the age groups that are younger started with much lower prevalence of use, and but they went down more than the last 10 years of age that started with much higher prevalences, and they stayed high. Some went down a little bit, but not as much as the younger women. Things, how these women look, so basically what we see is very similar to when we look at other comorbidities and other women in these databases. We have, I think, the most common comorbidities, anxiety and depressive disorders in all these countries for these women. And in terms of co-medication, we were really interested to see what we would see in terms of hormonal contraceptive, because, as you know, women that are taking this medicine are recommended to be using contraception. And what we see is that we see relatively very low prevalences of use of hormonal contraceptive in these women, and this is probably more a problem of we're not capturing all the contraceptive use that's really happening, probably because these are not included in some insurance in different countries, and how contraceptives are really prescribed, we're not seeing it here. So in terms of dose, we don't see very big changes in the initial dose as expected. And cumulative dose, we see a decrease in the Spanish database, but the other databases have very, very similar cumulative annual dose for the period we studied. So with that, yeah, what we've seen is that the incidence of prevalence of use of valproate among women of childbearing age have declined in all the countries we studied, especially in younger women, so that's reassuring, and that doses didn't change over time. And basically also, I think we'll talk more about this in the following days when you see other Darwin studies and the Darwin special talks, but we did this from protocol approval to report in around 2 months with winter holidays in the middle. So standardizing analytics, having a common data model, we can do these things really fast and have evidence ready to use for the regulators. Very, very timely. So here's again the report and the Shiny app if you want to have a look. And yeah, thank you for your attention, and I'll take any questions.
Thank you very much for this really interesting presentation and for being perfectly on time. So you left more than 5 minutes for questions. If there are questions, just get up and go to the mic, present yourself, and
Hi, Victor from Karolinska. Could you tell me what happened in Spain in 2015? It was the Spanish data where you had this bump, right? Upward trend? There, like why does it go up until 2015, 2016? Was there some changes in practice?
We don't really know what happened there. We hypothesize that it could be due to changes on who's prescribing these drugs, if it's primary care or a hospital or the things or things like this. But we didn't really know what happened there.
But you think the data coverage is good all the way, so it's not a data coverage thing, it's a routine thing?
Yeah, I think the data coverage is good from 2006, something like this in CDAP. So yeah, it's something that we see that could be something more organizational on who's prescribing and what we can see in the data in prescription, I think. But I don't know.
Oh, thank you, fascinating.
Mary Anthony, RTI Health Solutions. I was really intrigued with how low the use of contraceptives was in this group. Are oral contraceptives not the most commonly used contraceptives? Or are they not captured?
I think it's probably a little bit of both things. Like here, we won't capture any non-oral contraceptives and in most of these countries, contraceptives in some countries are not covered by the health systems, or maybe one of them is covered and the women prefer a different contraceptive. So we won't be capturing all these things, and I think that's a problem. We don't have good information on contraception in these
Okay,
countries.
thank you.
Yeah.
are there other questions? So then I would like to ask you, you defined the use as just at least one prescription, right?
Yeah.
And do you think, I mean, this is prescribing, this is not intake. We know that it's the best proxy we can use, but do you think it makes sense to make, for example, a sensitivity analysis in which you define at least 2 prescriptions or something in order to define chronic use?
Yeah, I think what happens here is we construct eras of prescription. So if someone, we also have duration, I didn't show all this, but if someone has a prescription, then in some days they have another prescription. We basically merge all these prescriptions into one. So we also have data on the mean prescription time and so on, but it could be a good idea to look at long prescription time.
And another question is, if I saw it right, in Germany, the line was always very low. So I wondered, may this have something to do with the availability of alternative anti-epileptic drugs? So maybe there were, from the very start, there were other drugs which were more used in Germany, for example, which were not available in the other countries?
We look at alternative drugs, and we don't see that Germany has higher use than the others. I think this is more a matter of the kind of data we're using here. Germany is a mix of secondary care and outpatient, and it's a little bit different. I think it's not like in primary care in Spain or in the UK, where we can capture much better the denominator also and the numerator.
Thank you. If there are no other questions, we can pass on to the next speaker. Thank you again, Albert.
Thank you.
So the next speaker is Anaïs Havet. for determinants of non-compliance with the pregnancy prevention program in women initiating oral isotretinoin therapy, a cohort from the French nationwide claims database.
It's one of these, yeah. No, on the PowerPoint. Or did you have the PDF?
No, also PPT version.
Is it here?
No. No.
Is it this one? No. I'm afraid it's only the PDF. Is that okay for you?
No, it's not my presentation, but PDF. tant pis. It's possible to.
I think that's okay.
Good afternoon, everyone. Anaïs Savé, I am a pharmacist and epidemiologist at the Reshape Laboratory in France. Thank you for giving us the opportunity to present our work about the determinants of non-compliance with the pregnancy prevention program among women initiating oral isotretinoin therapy. I have no conflict of interest to disclose. So, oral isotretinoin is a treatment for vulgaris acne, and to date in France it is indicated as first-line treatment for very severe acne. And among adverse effects related to this drug, we are interested in its teratogenicity and in the implementation of the French Pregnancy Prevention Program, or PPP. In particular, do women use effective contraception during treatment? Do they perform correctly pregnancy tests and have new prescription every month? Is drug dispensed within 7 days of prescription? In France, around 180 pregnancies were potentially exposed to this drug in 2019, but determinants of PPP non-compliance are still undervalued. So the aim of the present study was to assess the determinants of PPP non-compliance among women of childbearing age in France between 2013 and 2021 using the nationwide claims database. This retrospective cohort was conducted using the French National Health Data System, which contains claims data of outpatient care linked to hospital data. The study population was all women of childbearing age, that is to say age between 11 and 50, with a new dispensation of oral isotretinoin between 2014 and 2021 without prior dispensation of this drug in at least the previous 12 months. According to French guidelines, at initiation and renewals, PPP compliance corresponded to the completion of a pregnancy test within 3 days prior to the prescription and a dispensation within 7 days of prescription. At the end of treatment, it corresponded to the completion of a pregnancy test within 4 to 6 weeks of the end of treatment. Then we studied the determinants of PPP non-compliance with log binomial models at initiation and at the end of treatment, and with Poisson model at renewals. The determinants were age, socioeconomic level, prescriber specialty, the use of long-acting contraception with implants and intrauterine devices, the year and season at initiation, and also accessibility to physicians, laboratories, and pharmacies. For example, the accessibility to pharmacies was measure of a patient's place of residence and corresponded to the number of pharmacies per 100,000 inhabitants. A total of 272,723 women initiating oral isotretinoin was identified. The average age was 24 years. 60% of women were aged between 11 and 24. Regarding socioeconomic level, 10% of women had complementarity, solidarity, health, a proxy for low income. 26% resided in the least deprived areas and 40% in the most deprived areas. Regarding the PPP non-compliance between 2014 and 2021, it was 39% at initiation, 29% at renewal, and 89% at the end of treatment. Here we can see the results about the determinants of PPP non-compliance at initiation, renewals, and at the end of treatment. The results are presented as relative risk. So overall, women aged between 35 and 50 were less compliant with PPP compared to women aged between 11 and 24. But we can see that at renewals, women aged between 25 and 34 were more compliant with PPP compared to younger women. PPP non-compliance increased with low socioeconomic level, in particular among women having a complementarity, solidarity, health, and among those residing in the most deprived areas. PPP non-compliance decreased with the use of long-acting contraception and increased when treatment was initiated by general practitioners or other prescribers compared to dermatology specialists. PPP non-compliance decreased with the initiation year and increased when treatment was initiated during summer compared to fall. Also, PPP non-compliance decreased with accessibility to general practitioners and dermatology specialists, but increased with high accessibility to pharmacies and laboratories. So we observe that PPP non-compliance increased among women aged between 35 and 50, and one assumption is that a proportion of these women were postmenopausal, single, were with less sexual intercourse and therefore did not need to comply with the recommendations. PPP non-compliance decreased when treatment was initiated by a dermatology specialist. In fact, he has a better knowledge of its adverse effect and condition of use. PPP non-compliance increased when treatment was initiated during summer vacation periods, which is less favorable to follow the recommendations, and it's not recommended to initiate this drug during UV periods due to its risk of photosensitivity. PPP non-compliance also decreased with accessibility to physicians, but unexpectedly increased with high accessibility to pharmacies and laboratories. It should be noted that this study was only based on dispensation data, not use, but treatments had several renewals over several months with 93% of treatments with at least one dispensation, and unfortunately, a few behavioral lifestyle data are available in the SNDS database, such as sexual activity, menstruation, or menopause. So to conclude, this large cohort has highlighted that temporal and socioeconomic determinants, as well as age and accessibility to healthcare, could be taken into account to improve PPP recommendations and tailor them to specific subpopulations. Thank you for your attention.
Thank you very much, Anaïs, and perfect time. Any question in the room?
Maarit Leinonen, Finnish Institute for Health and Welfare. Thank you for your presentation. With regard to the older woman, or if it's 35 plus is older or not.
Not so older.
So you had information on long-term contraception devices, but did you have information on, for instance, sterilization? Because that could be one mechanism for contraception among older women, which you may not necessarily capture, and I think you would be very careful making assumptions about the sexual intercourse and habits among older women if you don't have information on all possible contraception methods. So do you capture the sterilization?
Information about short contraception? No.
No, sterilization among older women. Because usually there are requirements that you have to be older than 30 and have at least 2 or 3 children in order to get the sterilization.
Yes, it's a good, very good comment. Yes, I think in the SNDS database we have information about sterilization, but we did not take into account this data in our analysis.
Thank you.
Other question? No questions? No additional question? So maybe one question. Have you described how were pregnancy tests were identified in the database?
Pregnancy tests were only based on the reimbursement of serum or urine beta-HCG dosage performed in laboratory because the over-counter pregnancy tests are not reimbursed, so not identified in the SNDS. But we assumed that pregnancy tests were negative because in the SNDS database the results of biological tests are not available, so we assume this.
Okay.
Question from my side, why did you only include the long-acting contraceptives?
This is due to the quality of data, because in France, all implants and intrauterine devices are reimbursed by the French health insurance and so identified in the SNDS database. And it's not the case for some short contraception, some pills. And also the use of condom was reimbursed in France since 2018, so we only use long-acting contraception in our analysis.
Thank you very much. So we can then switch to our next speaker. And it's Dima Cuarto from the University of Southern California, and she will speak about the impact of the US Supreme Court Stops decision on the use of oral preventive and emergency hormonal contraceptives. The floor is yours.
I did, yeah.
It's down here. It's one of those.
Oh, you downloaded. Okay, great. Thank you. So for those who are not familiar with the U.S. abortion landscape, last year in June of 2022, the right to abortion was eliminated at the federal level, so it became a state option. So in this presentation, I'll be talking about trends in the use of oral, specifically contraceptives, oral contraceptive pills, as well as emergency contraceptives prescribed, changes before DOBS as well as after DOBS. Some acknowledgements from our co-authors. Before that, I want to give some background on how oral contraceptive use has changed. And what we have, the information we have is current as of 2019. So what happened in the US prior to DOBS was oral contraceptive use has declined, and that was attributed mostly to the use of long-acting reversible contraceptives like IUDs and implants. But the overall use of contraception did not really change. about 2/3 of women use contraceptive methods. And oral contraceptives continue to be the most common reversible method of contraception used by women in the US. This is before Dobbs. And this is the most current data we had before this study. The use of emergency contraceptives, I think, are interesting because they're available over the counter, and their use has increased for a variety of reasons, including being available over the counter. But what I think what's lesser known is how prescriptions for emergency contraceptives have been used in the US. And that's important because they cost about $30 to $45 to buy one pill over the counter, so they could be pretty expensive for low-income women that may otherwise not afford to buy them when they need them. And what we also know is that by 2017, 2019, about a quarter of women used emergency contraceptives at least once in their lifetime. So this is important because during this time where we saw a decline in use of oral contraceptive pills, as well as an increase in the use of emergency contraceptives, unintended pregnancies as well as abortions in the US, nationally at least, declined. And these are reports from the Guttmacher Institute as well as the Kaiser Family Foundation. So it's really important to improve and ensure access to oral contraceptives, particularly after the Dobbs decision, where in states where abortion is no longer an option for most women. So really the objective here then is to evaluate these trends nationally and across states with varying levels of abortion access after Dobbs, and to examine this association, the association between the Dobbs decision and oral contraceptive use by state abortion access policies as well as at the state level. And to do this, we use several data sources. Our primary data source where we got our information on prescription fills was IQVIA's NPA, or National Prescription Audit, and payer track data, which provide national and state level information on all prescriptions dispensed, projected from 92% of prescriptions in the US, but they represent all prescriptions dispensed at retail or mail order pharmacies. We use the Guttmacher Institute abortion policy tracker to classify states into 4 categories based on their abortion restrictions, ranging from full ban to legal with protections, and the American Community Survey to derive information on the total population of women of reproductive age, which we define as 15 to 49 years. And our primary measure was monthly rate of prescriptions dispensed per 10,000 women of reproductive age, so 15 to 49 years nationally and at the state level. And we use these ATC categories to define oral contraceptive pills as well as emergency contraceptives, which include both the Plan B over-the-counter formulation as well as LL, which is only available by prescription. And we did descriptive analysis to examine trends over time since 2019. And this figure here is, and this is adjusted for day supply, and we see, similar to patterns prior to 2019 that were previously reported, that oral contraceptive pills continue to decline, even after Dobbs, nationally and across states with varying levels of abortion restrictions. And it's approximately 13% of women, or 1,300 prescriptions per 10,000 women of reproductive age nationally. And that's consistent with, for 2019, that's consistent with the estimates using survey data nationally in the US. And that's important just because of the data. The data source doesn't represent perhaps prescriptions dispensed at Title X or family planning clinics, which provide services to approximately 10% of women in the US and dispense oral contraceptives on site. What I think is really interesting is, as expected, right? We heard reports in the USO, demand for Plan B has skyrocketed, and pharmacies are putting, controlling the amount of Plan B that's dispensed per woman. And what you see here with these data, and these are prescription, dispensed at pharmacies, is that they did increase substantially. They steadily increased prior to 2022, but then began to increase even beginning in early 22 after the leak, and then peaked to their highest point nationally and across all state categories 1 month after the Dobbs decision. But what we find here in this figure, which I think is interesting, is that states, which are the blue line, these are states that where abortion is legal with protections. And you see it increased substantially here, but this is the only state category where the declines really didn't return to baseline levels. Whereas in full ban and partial ban states, and even in states where abortion is legal but there's restrictions, by June 2023, which is the last 6 months during that 1 year post-Dobbs, they returned back to baseline levels or 2021 levels. In this table, I kind of summarize the patterns across 4 time periods. And we see that, again, for oral contraceptives, their use is similar across state categories and declined post-Dobbs, as it was declining before. For emergency contraceptives, as was suggested in the prior figure, in full ban states by January and June 2023, which is the most recent period available after Dobbs, you see that the prescription, all states had an increase or a surge that was temporary after the Dobbs decision. But full ban states, as well as these, to a lesser extent, the other restrictive states, that use declined back to baseline. So, there aren't more women using emergency contraceptives, even though abortion is still banned in these states, and you expect those increases to happen. These next few slides kind of look at how this varies across state. So contraception, as is abortion now, there's a lot of policies that vary across states in terms of emergency contraceptive access, insurance coverage, even the right to refuse to dispense and prescribe contraception. So it's important to look at how, even within state categories that have abortion restrictions, how that varies across states. And as far as I know, this is the first study that looks at the use of oral contraceptive pills as well as emergency contraception after Dobbs. And you see here, for example, and this is surprising, California, but it makes sense, has the lowest rate per capita, even though it shouldn't, based on prior estimates. And this is largely, I think, related to the data coming from retail pharmacies. And California, as an example, unlike Massachusetts, which has the highest rate, and they are both states where abortion is legal with protections, but in California, a lot of women get their contraception, oral contraceptive pills particularly, from family planning clinics or Title X clinics. It has the most in the country, even per capita. Whereas in states like Massachusetts, a lot of women get their contraception maybe from private doctors, and they need pharmacies to fill those prescriptions. Similar patterns across states for emergency contraception, but what you see here now is really like Mississippi, a full ban state, is the only state in the US that prohibits Medicaid coverage for Plan B, even with a prescription. And you see the lowest rates here. And you see the highest rates all the highest rates are in protective states like Hawaii, Alaska, and there's multiple reasons for that, including policies that encourage and cover over-the-counter contraception, even without a prescription in the more protective states. So, in conclusion, I think we wanted and expected women to increasingly use preventative measures to prevent pregnancy, particularly oral contraceptive pills, given their accessibility, but they continued to decline. And although emergency contraceptives increased, within a first few months before and after Dobbs, they declined later. And that's concerning and suggests that many women in need of contraception do not have it, and they also can't really have an abortion. And we're trying, and we might see a reversal in the unintended pregnancy rates nationally, but also live births from unintended pregnancies in states where now abortion is not an option.
Thank you. This is surely a very interesting topic, and we could discuss a lot. There's room for 2 questions, so please, if you have a question, go to the mic.
Hello, great presentation. Clara Ziede from AbbVie. I was wondering if you are planning to kind of like have a complementary study where you look at male contraception methods, like vasectomy and other things that can play a role in the female contraception decline.
Yeah,
Thank
no,
you.
good question. I think there's speculation that maybe more, there's anecdotal reports, I think that more women now are opting with natural methods, more permanent methods like sterilization. But I did look at the use of LARCs, long-acting reversible contraception, and others have too. And unlike, in the period earlier, before 2019, where we saw an increase in LARCs, actually since 2019, they kind of leveled off. And in terms of retail pharmacies, they actually have declined steadily. So, if more women are now opting to, use more permanent methods, perhaps now they're protected and we're fine. But historically, that hasn't been kind of the trend. Historically, it's, if you don't have access to emergency contraception or contraceptive methods, especially if you're younger, and your insurance doesn't cover sterilization, you're at risk for having an unintended pregnancy.
Are there other questions? I would like to ask you, did you consider also to implement methods like interrupted time series or something?
Yeah, we did, and we actually did that first. But given the trends, especially for emergency contraception, are unstable and nonlinear, it didn't make sense to do them, especially earlier on. I think once we have more time points, we're able to. But when our preliminary analysis using ITSA kind of confirm what we found, but I think they quantify, they're just non-significant in some states and state categories, so we opted to just use these descriptive methods.
Yeah, you might still think about doing it for all the states together without stratifying. Yeah, thank you. Thank you very much.
Thank you. Ursula. So now it's Chaise Latour. I don't know if I pronounced correctly. For a presentation about new long-acting reversible contraceptive insertions, more than double among a commercially insured US-based outpatient population from 2010 to 2020. Floor is yours. Thank you.
Thank you. So just to reiterate, my name's Chase Latour. I'm at the University of North Carolina at Chapel Hill, and I'm really excited to talk to you today about new long-acting reversible contraceptive insertions among an outpatient, commercially insured, US-based population. So here are my co-authors' funding sources and also potential conflicts of interest, and these are all available on the posted slides. So long-acting reversible contraceptives, or LARC, are medical devices comprised of intrauterine devices and implants. And critically, they are highly effective at preventing pregnancy and require minimal effort from a patient once they're inserted. And there are current studies that have characterized LARC usage, but most have focused on prevalent LARC use, generally finding increasing usage over time in US populations. And this is really important, but LARC can remain in place for years, so these prevalence estimates don't provide information on new use among people who have not previously used LARC. And so this can be an important distinction in populations. For example, when studying the impacts of a policy on LARC usage, there might be differential impacts on people who are already using LARC compared to people who have never used it before. And so, as shown here, So there has been other research focused on LARC insertions immediately after delivery, and this has also found increasing usage of this form of contraception. But this is only a portion of insertions since LARC are otherwise inserted in outpatient settings. So there is a clear gap in understanding outpatient insertions of LARC among people who have not previously used LARC. And understanding new LARC use among patients in the U.S. is vital for characterizing patient desires, access to LARC, and provider counseling practices. And I just want to note here that we emphasize these three elements because LARC and sterilization have been used to exert power over the reproductive autonomy of people with marginalized identities, and that's particularly the case in the U.S. So circling back now to the goals of the study, we aim to describe trends in new outpatient LARC insertion incidents in a commercially insured patient population from 2010 through 2020. And data for the study come from the Merative MarketScan Commercial Claims and Encounters database. We constructed a cohort of individuals who were classified as female, 15 to 54 years of age, continuously enrolled in MarketScan for at least 180 days, and we focused on insertions that occurred between January 1, 2010 and December 31st, 2020. And at this point, I just want to clarify that from this point on, I'll be using the term individuals to reference this patient population because gender identity is not captured in MarketScan. So we identified new LARC insertions using a multi-stage approach. We defined insertions first as having a CPT code indicating that an insertion occurred. We then looked 180 days before and after the insertion to identify a HCPCS code that indicated the type of device that was inserted. And if there was no HCPCS code identified within this time frame, we did not consider that a qualifying insertion for this study. And finally, we confirmed if an individual with an insertion had a CPT code for removal in the 6 months prior to their insertion. And if we identified a removal code, we did not consider that a new insertion. We then calculated monthly incidence proportion of new LARC insertions as the number of new insertions in that month divided by the number of people with continuous enrollment in that month. And these monthly estimates were standardized to the age and geographic distribution of eligible individuals in January of 2010. And so just to illustrate this a little bit better, I've provided data for an example patient who has a continuous enrollment period over this entire period. And what we can see is that they have an insertion in March, so they would contribute to the numerator of this incidence calculation in March. And because we're calculating incidence, they are removed from the denominator once we see their insertion. So we calculated monthly incidence estimates from January 2010 through December 2020, the annual average of monthly incidence estimates, the percentage of insertions attributed to implants, hormonal IUDs, and non-hormonal IUDs annually, and then monthly incidence estimates stratified by patient age. So here you can see a plot of the monthly incidence where month is on the x-axis and LARC insertion incidence is on the y-axis. Overall, we found that new insertion monthly incidence more than doubled over the study period from January 2010 to December 2020. Specifically, in January 2010, we estimated new insertion incidence to be 6 per 10,000 individuals, and in December of 2020, this was 14.1 per 10,000 individuals. But we do see a really major dip in new LARC insertion incidence in March through May of 2020, and this aligns with the start of the COVID-19 pandemic and associated lockdown measures in the US. So shown here is that same plot, but we've just restricted to 2020 only so that we can clearly visualize the changes associated with the COVID-19 pandemic. And we can see that the largest dip in incidence occurs in April of 2020. But we see that the incidence actually recovers very quickly. So by July of 2020, it's comparable to those estimates that we have in January and February of 2020. However, we can zoom back out again to that original plot, and it's clear that there is not a compensatory increase to make up for those insertions that would have been expected in March through May of 2020. So this point becomes even clearer, at least to me, when we look at annual estimates. So in this table, you can see the average number of eligible enrollees per month and the annual average of the standardized incidence per 10,000 individuals of each year. And we can see that there was a monotonic increase in incidence through 2019. However, we saw a decrease in incidence from 2019 to 2020. And in fact, 2020 had a lower insertion incidence than 2016 to 2019, with an estimate that aligned with that from 2015, which is a major dip. Transitioning then to the type data on this figure, we can see year on the x-axis and the percentage of insertions attributed to each LARC type on the y-axis. Black dots correspond to hormonal IUDs, red to non-hormonal IUDs, and blue to implant. And the first major takeaway here is that hormonal IUDs were consistently the highest percentage of insertions over the study period at about 68% of insertions. However, there were major changes in other LARC types, specifically implants increased in the percentage of new insertions from 8.5 to 21%. And then conversely, non-hormonal IUDs were consistently less used over the study period, going from 19.9 to 10.9% of insertions. And then finally, we can briefly consider those insertion estimates by age group. We show here plots of the monthly insertion incidence, stratified by the person's age at that month. And in general, we can see that the trends very much reflect those that we saw in the overall study population. But it's really clear that the incidence of new LARC insertions is highest in the youngest age group included in this study. And this is not a surprising result. We would expect that the majority of new LARC users would be younger individuals, particularly since they've just had less time to have previously had a LARC. So as we conclude, I want to circle back to the gap that this study was intended to fill. Previously, we've had little data regarding new LARC insertions among non-users in the outpatient setting. And overall, our results demonstrate increasing popularity of LARC among privately insured reproductive age people in the outpatient setting, which aligns with a lot of prior work. And our study has important strengths. We defined a measure of new LARC usage and identified changes in LARC type over time. And we assessed changes in LARC incidence in the early months of the COVID-19 pandemic. But I want to be very clear that there are some important limitations. Most clearly, the validity of our new use definition is heavily reliant upon the accuracy of removal codes and assumes no major gaps in usage, which is likely not true across our study population. But given that these trends hold across age groups, particularly in the younger ones, we expect that even if the incidence estimates are not exactly correct, the trends in incidence are. So based upon these data, it is paramount that stakeholders, policymakers, payers ensure access to LARC. And circling back to Dima's presentation, the overturning of Roe v. Wade by the Dobbs decision has led to decreased access to abortion. It is not a guaranteed right. And so within this context, while it's always been critical, access to highly effective forms of contraception has an even greater potential impact on someone's life chances. So I want to thank my co-authors and folks at UNC who've supported me, and then thank you all for listening and open it up for questions.
Thank you very much, and perfect for the timing. Any questions from the room?
Mary Anthony, RTI Health Solutions. Chase, that was really, really nice. Thank you.
Thank you.
I don't recall if you told us how much look-back time you had for this.
Yeah, no, that's a great question. And I will actually take us back to the figure, hopefully quickly. So we just required 180 days of continuous enrollment, but we actually did not require a washout period before, which is definitely not standard compared to like if you were trying to do a new user study. But we felt like our hands were tied and that we wanted to have a representative sample, but we didn't want, and people can truly get new insertions a month after being enrolled in their health insurance plan, so it was not standard, the amount of continuous enrollment they had before the insertion. Yeah, thank you.
Hi. Oh, what did I do? Uh-oh. Hi, Stacy Abramsky-Rissman from Boehringer Ingelheim. Thank you. This is a really important presentation, and very complementary to the one that preceded it. And I'm sort of melding them together in my head a little bit here, but I'm sort of starting to wonder, like, and I don't really know the answer to this, like a lot of the states that have become quite restrictive or completely restrictive, what are the, what's the coverage, like, say, like Medicaid, what's the coverage like for LARC in those places? And you may not know that because that may be looping back to the previous presentation, but like, I'm just, what is the coverage like for these LARCs? And because in particular, it feels like these are going to be, so, as you said, so much more important moving forward, particularly in certain geographies in the US.
Mm-hmm.
Can you speak to that at all?
Yeah, I will do my best, and Dima, if I say something wrong, feel free to correct me. It's my understanding that the Affordable Care Act now requires insurance payers to cover LARCs. So they should be covered. So, just,
Just add to that, I mean, they should be, but I think recent reports have shown that there's a lot of non-compliance with
that was where I was sort of thinking.
So, I think it would be interesting to see these trends by payer, because some initial analysis in at least retail pharmacy data shows declines in Medicaid more so.
helpful. Yeah.
Can you use the
I was just saying that even though the ACA requires or mandates coverage for LARCs, there's issues of non-compliance with that mandate. And a lot of states are kind of being exempt from that mandate, at least, you know, after 2019 or 2017. That's one. And two, I think for Medicaid, there are some studies that it hasn't really increased, and there are differences between the use of LARCs in commercially insured versus Medicaid populations. They are much lower in Medicaid populations. Whether and how that's changed over time, I think that's to be determined.
Thank you.
Hey Chase, nice talk.
Thanks.
Great work. I was just thinking, you mentioned that one of the limitations is that you only had 185 days look back, so someone who had insertion like 4 years ago, you will not be able to identify that, right? So have you considered looking at removal codes to maybe just as a sensitivity analysis to see like how big of misclassification you may have introduced by the limited amount of look back that you have?
So I'm just trying to clarify your question. We did include removal codes in our primary definition, but are you suggesting further back?
Yeah, I mean, sometimes so you looked actually at removal code during the study period.
Yeah,
That's
we
great.
did. Yeah.
And then sometimes you don't really see removal code, right? I don't know if you have looked at that.
So yeah, they're not always going to be there.
Yeah.
I did learn at another conference, and I have not been able to confirm it, but in the US, I think removals are actually reimbursed higher than insertions, which makes no sense. There's very different skill levels required, but if that holds, it would suggest they should be recorded relatively well. We did do some sensitivity analyses with different amounts of look back in a 1% sample, only 1%, but nothing changed really.
Okay, perfect. Yeah, I just wanted to follow up on that. Great work.
No,
Thank you.
Thank you.
Thank you very much.
Thanks again. We can then move to the next presentation. Tanja Schink from the Leibniz Institute in Germany will speak about the use of anti-thyroid drugs during pregnancy and with a focus on switching patterns and changes over time.
Thank you. This is now a very different topic to the previous presentations. This project was funded by the German Federal Institute for Drugs and Medical Devices, BfArM. However, BfArM was not involved in the study design and the collection, analysis, and interpretation of the data. Hypothyroidism is associated with maternal, obstetrical, and fetal complications during pregnancy. Antithyroid drugs, ATD, are the main therapy for hypothyroidism. Observational studies, however, show an increased risk of birth defects for carbimazole and methimazole, CMZ, MMI. Propylthiouracil, PTU, is assumed to be the safer alternative, even though it can induce liver injury in the mother. The Pharmacovigilance Risk Assessment Committee, PRAC, of the European Medicines Agency, EMA, stated in November 2018 that hyperthyroidism in pregnant women should be adequately treated to prevent serious maternal and fetal complications. Women of childbearing potential have to use effective contraceptive measures during treatment with CMZ, MMI, and that the use of CMZ, MMI in pregnant women must be based on the individual benefit risk assessment. Hyperthyroidism is mostly caused by Graves' disease, and the respective guideline of the European Thyroid Association on the management of Graves' hyperthyroidism in 2018 stated that women with Graves' hyperthyroidism of reproductive age should be offered preconception counseling and be stably euthyroid before attempting pregnancy. Women treated with CMZ, MMI should be switched to PTU when planning pregnancy and or during the first trimester of pregnancy. And a switch from PTU to CMZ, MMI after 16 weeks of pregnancy should be considered. Therefore, the objective of our study was to assess the occurrence of pregnancies under ATD and to examine switching patterns between CMZ, MMI, and PTU before and during pregnancy and their changes over time. We used data from the German pharmacological research database JEPARD, which contains data from 4 statutory health insurance providers and has information on about 25 million persons insured with one of the participating providers since 2004 or later. It has information on drug dispensings, outpatient and inpatient services, procedures, and diagnosis. Pregnancies are identified based on a validated algorithm, and pregnancy onset is estimated using the expected delivery date, which is based on the last menstrual period and early ultrasound. We additionally search for pregnancies with no recorded outcome, but a combination of a plausible expected delivery date and a diagnosis or procedure indicating a pregnancy. We identified all pregnancies exposed to ATD between 2005 and 2020 in a previously established cohort of more than 57,000 female ATD users aged 13 to 49 in JEPARD. The supply for dispensing was estimated as twice the number of dispensed defined daily doses. And exposure was defined as an ATD dispensing during pregnancy as indicated by the violet cross. This one, no. Here. Or in supply overlapping pregnancy onset. So we had here start of a dispensing, and then the supply would overlap the pregnancy onset, and both were considered exposure. Overall, we observed 13,586 pregnancies in 9,723 women. The median age at pregnancy onset was 33 years. About 2/3 of pregnancy were not exposed to ATD. 16% of pregnancies, the woman was using ATD at pregnancy onset. Thereof, 83% were using CMZ MMI, and 70% was PTU. In 17% of the pregnancies, ATD use was started during pregnancy, and there, half of them started with CMZ MMI, and the other half with PTU. 82% of the pregnancies ended in live birth and 0.4% in stillbirth. 3.4% induced abortions were observed, as well as 1.4% spontaneous abortions and 1.5% ectopic pregnancies. And we observed 11.4% pregnancies with no recorded outcomes, which would have been missed if we used the standard algorithm. In the group of pregnancies where ATD was used at pregnancy onset, overall 83% were exposed to CMZ MMI. And as you can see in this figure, this percentage didn't change much over time. In the group of patients or pregnancies that were exposed to CMZ MMI at pregnancy onset, overall 30% had an additional CMZ MMI dispensing during the first trimester. And this percentage decreased from 42% in 2005 to less than 30% since 2016. In the same group, 17% overall switched to PTU during pregnancy. And as you can see in this graph, there's a slight increase in the numbers of switchers. However, there's a slight bump, dent 2017 and 2018, which is probably due to more and more coming reports of potential liver disease. In the group of pregnancies that were exposed to PTU at onset, overall 55% had switched from CMZ MMI before pregnancy, in median 5 months before pregnancy onset. And here you can see that these number of switchers increased over the years, with 44% in 2005 to 2008 and going up to 75% in 2020. In the group of pregnancies that started ATD use during pregnancy, overall 50% started with CMZ MMI in median 11 weeks after the beginning of the pregnancy. Sorry. As you can see in this graph, this number, or the percentage of those who started with CMZ MMI, decreased from about 70% in 2005 and 2006 to less than 40% in 2019 and 2020. As all observational studies, our study has several limitations. First, dosing of ATDs depends on the severity of hyperthyroidism, lab values, and the treatment regimen, titration or replacement. In German claims data, neither the prescribed dose nor information on the severity of hyperthyroidism nor lab tests are available. We therefore used a very pragmatic approach using DDDs, which may overestimate the length of the treatment episode. This might lead to an overestimation of exposed pregnancies. Women might also stop using ATDs once they learn that they are pregnant, especially in the first weeks. This might also lead to an overestimation of the exposed pregnancies. Strengths of our studies are that the size and the representativeness of our study population, the use of a validated algorithm for the identification of pregnancies, the estimation of pregnancy onset using the expected delivery date, which is based on the last menstrual period and early ultrasound, and especially the inclusion of pregnancies with no recorded outcome, which in our case accounted for more than 10% of the observed pregnancies. In conclusion, in the majority of pregnancies in our study population, no ATD were used during pregnancy. And physicians are becoming increasingly aware of the potential risk of CMZ MMI as indicated by the decrease in the number of CMZ MMI dispensings in the first trimester, the increase in the number of switches to PTU before and during pregnancy, and the decreasing numbers of starters with CMZ MMI during pregnancy. Nevertheless, there was still a relevant number of pregnancies that were exposed to CMZ MMI during the critical time window. We want to thank the statutory health insurance providers AOK Bremen-Bremerhaven, DRK Gesundheit, Techniker Krankenkasse, and HKK Krankenkasse for contributing data for this project. And also thanks to the German Federal Institute for Drugs and Medical Devices for funding, and many thanks to Alina Ludewig and Inga Schaffer for programming the analysis datasets. Thank you for listening.
Thank you, Tanya, for being perfectly in time. So we have time for questions. I can ask you the first question. You said yourself that one of the limitations is that you might have overestimated the use also because you considered the prescriptions overlapping, which were prescribed before and then had like the duration overlapping in the pregnancy. Did you consider to perform a sensitivity analysis taking them off?
We did that, yeah. So we had a sensitivity analysis where we excluded those. However, this did decline the numbers, but not that much as we thought. The problem is, what I fear mostly, the recommendation is to stop for like 3 weeks or 4 weeks in the critical time window, and I think it's hard with any sensitivity analysis to really get this. And as I said, the study was funded by the BfArM, by the regulatory authority, and they wanted to rather have us to overestimate than to underestimate exposed pregnancies.
And then again, I remember that you said that the recommendation is to switch back to the first drug group after the third trimester. Did you show that? Maybe I missed that, but did you show the switch back also? Did you measure that?
The problem is the numbers of those who switched were already small, and we looked who switched back, and the numbers were very small. And when you then want to look at time trends, it becomes very yeah, very raw data. And the recommendation is only given by the guideline. So the regulator was more interested in no use at all, and they didn't really like the switching and reswitching things.
And do you think that these data can be useful for clinical audit or something? For, like that these results might be interesting for clinical audit with the prescribers in order to show that there's still a conspicuous number of people using the drugs?
Actually, whenever we do a study for the BfArM, they have a journal which goes around to all physicians, and we reported this. So we hope that this changed things. And usually, when we observe something like this, that there's still a lag, they usually send what we call Rote Handbrief, so a letter to all physicians to inform them on the results.
Are there other questions from the audience? Okay, thank you very much.
Now we welcome for the last speak Felix Wiström from Sweden to speak about lithium in pregnancy, a utilization study in the 5 Nordic countries. The floor is yours.
Thank you very much. My name is Felix Wiström. I'm a medical doctor and PhD student at the Karolinska Institute. And together with my colleagues from the 5 Nordic countries, I've been working on this study investigating the use of lithium in pregnancy. It was funded by a research grant from Forte, and other than that, I have no conflicts of interest to disclose. For those of you that aren't familiar with lithium, it's a drug that's typically used to prevent relapse in bipolar disorder, to prevent the patient to go into depression or mania. But it's also used in other severe mood disorders like schizoaffective disorder or recurrent depressive disorder. And since these disorders typically are very chronic, the treatment may be continued in pregnancy. But it's a difficult balance for the clinician and the mother, because the benefits of preventing relapse has to be weighed against the risks of continuing treatment. And for the clinicians and for the mothers, there is a lack of information about how lithium is used in and around pregnancy. We were able to identify a few drug utilization studies investigating the topic. They were from different parts of the world, as you can see on the map here. 3 of them, they investigated lithium use in pregnant women with bipolar disorder. And for this group, it seems that 10 to 30% use lithium during their pregnancy. We also found 3 other studies having a more broad scope investigating lithium use in pregnancy in general. And they suggest that less than 0.2% of pregnant women use lithium. But some of these studies were very small, and they had very differing methodology, and they really didn't investigate the use of lithium around pregnancy in a consistent way. So that's why we wanted to do our study. With our study, we aimed to describe the utilization of lithium in the Nordic countries. But we also wanted to do so before, during, and after pregnancy, as well as investigating the prevalence trends over time. And finally, we also wanted to look at the characteristics of the women using lithium in terms of what diagnoses they have and what other prescriptions they fill. To do so, we used the nationwide health registries in the Nordic countries, where we have prescription data, birth data, and diagnostic data linked. We had data for the years that you can see on the slide here, and when we looked at the trends for these years, we investigated prevalence trends as 3-year moving averages. The reason for this is that for some of the smaller Nordic countries, the number of women with lithium use could vary very much. And to smooth this out, we used moving averages. We looked at what we defined as the pregnancy period, which you see in orange here on the slide, which started 3 months before last menstrual period and lasted until birth. So all the women in our study with at least 1 prescription fill for lithium in this pregnancy period were considered as lithium users. And the reason for including this pre-pregnancy period is that the supply from that prescription could last until pregnancy. For those women having a prescription fill in this period, we also investigated specialist care diagnostic codes and prescription fills for other psychotropic medications. For the diagnostic codes, we looked 1 year back, and for the prescription fills, we looked 3 months before conception. And finally, we also looked at these distinct time periods in and around pregnancy that you can see in blue here on the slide. We specifically looked at prescription fills in the pre-pregnancy period, the first trimester, the second trimester, third trimester, and the post-pregnancy period. So what did we find? On the figure here, you see the trends in lithium use in the 5 Nordic countries, where each color represents each country. On the y-axis, you have the percentage of pregnancies with lithium use, and on the x-axis, you have the year. It's quite clear from the figure that the trend is increasing. The prevalence trend is increasing in all the countries, even though the smallest country, Iceland, the gray line that you see, is still very jumpy due to the small numbers. Taken together, we had 0.02% of pregnancies with lithium use in 2006. That went to 0.06% of pregnancies in 2016. And overall, we had 4.5 million pregnancies, with around 2,000 of those with lithium use. When we zoomed in and looked at these 2,000 pregnancies with lithium use, we saw that a great majority had a diagnosis of bipolar disorder, 81%. Other diagnoses associated with lithium use, such as recurrent depressive disorder or schizoaffective disorder, were not very common. When we looked at other medications used by these women, we saw that many of them had antidepressant prescription fills or antipsychotic drugs, while around a quarter had anti-epileptic drugs. Finally, we also looked at the lithium use before, during, and after pregnancy in these 5 distinct periods that I talked about. So in this figure here, you see the number of pregnancies with a prescription fill for each of the 5 periods and for each of the 5 Nordic countries. And you should note that the axis is different for the different countries, as of course they are of different size. But nonetheless, the trend is quite clear in all of them. There are more prescription fills in the pre-pregnancy and the post-pregnancy period, if you compare it to the 2nd and 3rd trimester. This trend is varying in strength for the different countries, but it's quite clear for all of them. Yes. So what do we conclude from this data? Well, first of all, we conclude that the use of lithium in pregnancy has been increasing in the Nordic countries. It tripled from 2006 to 2016. Second, we conclude that most of the women using lithium in pregnancy have bipolar disorder. And additionally, many of them use other psychotropic medications at the same time. Finally, we conclude that some of the women using lithium in pregnancy discontinue their treatment during pregnancy, as indicated by the lesser use in the 2nd and 3rd trimester. And additionally, some of these women that discontinue seem to reinitiate treatment after birth, as we saw that the number of prescription fills post-pregnancy was almost as high as pre-pregnancy. So what are our plans with this data? Well, we're already underway with a larger utilization study involving 14 different countries and territories. It spans all the different countries that you can see on the map here with arrows. And we plan to publish the results from the Nordic countries together with these other data sources as well. And finally, for my part, and as part of my PhD, I plan to further investigate this topic of lithium discontinuation, as I find it very interesting and especially relevant to investigate what the clinical consequences of discontinuation or switching medications during pregnancy can be. Thank you. Any questions?
Maybe I have a question, but maybe you answer. I was wondering if you plan to study maybe women who stop lithium during pregnancy versus women who continue lithium during pregnancy in terms of impact on management of disease for the mother, but also for the children after that. In terms of impact, I think it's very important.
Exactly, very good question, and yes, that's that's part of the plan to look at this discontinuation phenomenon. But it is of course very complicated because it's hard to find an exact time point when the mother stops the medication, and also it's not only about discontinuation. Perhaps maybe some other switch medications to. In the clinic, it's very common with switches to antipsychotic medications, but also anti-epileptic. But it's a very relevant topic, which I'll look further into.
Thank you for a very informative talk. I'm Sasha Devlin from Kaiser Permanente. I wondered if you could speculate a little on the reasons you think might be behind the increasing use, if there were new knowledge or new indications or thoughts you might have had about why it seems to be going up so markedly.
All right. I mean, it's a good question, and I thought about it, of course, when looking at the data. I tried to find some studies just investigating the lithium use in the general public, and that seemed to be decreasing actually in many countries. I tried to find some data on women of childbearing age. That was a bit more difficult to find any data. That would be a relevant comparison, right, to see in that group how is lithium use. I was able to find some publicly available data from Denmark indicating that in this age group, lithium use is also increasing. So it could, of course, be that it's just increasing in this patient population. But you should also remember it could also be that perhaps more women using lithium from the start become pregnant. It could also be that way around. It's not only that maybe lithium use is increasing, but maybe pregnancy is increasing in that population.
Hi, Mary Dozier from Alexion. I think you touched on this a little bit with her question, but so with the discontinuation that you were discussing, are you planning to look at patients who potentially switch to anti-epileptics or other medications and then switch back to lithium?
Very good question. I mean, it's very connected to like the clinical reality of bipolar disorder treatment and treatment in pregnancy in particular. Many may switch to antipsychotics, which is maybe seen as a safer alternative in pregnancy, and some switch to other anti-epileptic mood stabilizing drugs. Some of them, for example, valproate, are not considered very safe in pregnancy. So it's a difficult clinical situation. And some of them switch back, right? And we can also see in the data the increase again in the post-pregnancy period. I haven't thought about it specifically, those that switch and then switch back. I think it's a very interesting clinical situation, which we should investigate, I think. Yeah, thank you.
Hi, Reza Afshari, Sanofi. You mentioned that there were some concomitant prescription of other medication, including anti-epileptic drugs. I wonder if you see some trends change on those as well. So when lithium went down, what happened to the others? Did you check that, or do you have any idea on this?
So we didn't investigate, since it's more a descriptive drug utilization study focusing on lithium. We didn't investigate if the use of other drugs increased, but that's definitely a topic for future studies which we planned to see, is there an increase perhaps in antipsychotics or anti-epileptic drugs when, and especially in the women which maybe discontinue lithium. Yeah.
Nice talk.
Thank you.
Did you also study the underlying trends of the epidemiology of the disease? Because I was wondering if in these last 2 decades there has been an increase in diagnosis, awareness.
It's a very good question. I mean, there is a discussion in psychiatric diagnoses that perhaps diagnosis of especially less severe mood disorders such as depression or anxiety are increasing. But from what I understand, in more severe mood disorders such as bipolar disorder, there hasn't really been an increase in diagnoses. And that's the main patient population that would be treated with lithium.
If there are no other questions, thank you to Felix, and thank you to all the speakers again for your nice presentations. Thank you for attending this session. Enjoy the coffee break.